Folks will start trickling in. So good afternoon, everyone. We've got people coming in from the waiting room here. So thank you for your patience while we got everything set up. My name is Angela Brandt, and I'm with NAMI California. And I want to thank you all for joining us today for our town hall with the California State Association of Counties, or also known as CSAC. This is part of our ongoing town hall series. Many of the names that I see in our participant list today, you have been with us since the beginning. And so I thank you for joining us today. And I thank you for your support and participation all the way through. For those that are just joining us for the first time, these town halls, we started a few months ago really with the intention of bringing together all of those folks working at the state level who are supporting our behavioral health system, helping to connect counties with state entities, really trying to better understand, who has a hand in what part of the behavioral health system, and how everyone's working together to support what's happening on the local level. And so before we get started, we have just a couple of small housekeeping things. And so let's go to the next slide. Again, for those of you that have joined us throughout, you're familiar with this, but for anyone who's new, we like to do some real-time polling during these events. And so we use a system called Mentimeter. And if you want to participate in the polling today, either on your smartphone or you can open a new tab in your browser, if you go to menti.com, you'll see that it pops up with a box to put in a code. And so the nice thing about this polling feature is that it's real-time polling, but it is anonymous. It doesn't require you to download an app or any sort of system on your computer or phone. And when we're done here today, it doesn't stay and track any of your data or information. So if you go to menti.com and go to the next screen, it'll have the code for you to pop in. So that code is 7699547. And once you put that in, it'll prompt you throughout this presentation with the polling questions that we have for everyone. And if you want to participate, we would love that. We love to kind of see who's in the room. We love to see who has some familiarity or experience with some of the things that we're going to talk about today. And if you don't want to participate through the app, you can also enter your responses in the chat box too, if you're more comfortable with that. So as we get started, we do have some house rules. These are put together so that when we're here today, we have a safe and inclusive space for all of our participants. We like to set up, we like to set up an environment where everyone can bring their collective experience and perspective to the table and ask questions and get more information so that, we're all on the same page about, what we're hearing today. So for those of you who can't see the rules on the screen, if you're participating by phone, those rules are to be kind and courteous, to listen attentively with an open mind, to speak honestly, share the space, learning leaves, but names stay, step up and step back, and finally reserve the right to change your mind. And then as a reminder, this webinar is being recorded. We record all of these sessions so that we can provide them to those who aren't able to make it today. We post them on our website. And for those of you here today, we'll send out a link to the recording of this town hall along with the materials that CSAC staff will be going over. So if at any time you have questions, thoughts, things that kind of come to your mind, please go ahead and use the chat box. If we can answer the question throughout the presentation, we will. Otherwise, we will have time for Q&A after the presentation, and we can take your questions directly from that chat box. We'll go to the next screen. So the first one here, again, this is just to kind of get a sense of who's in the room today. So we're just asking, what county are you joining us from? We'll give everybody a minute to get their responses in.
And you want us to use the Mentimeter program to respond, right? Not the chat?
Either or, whatever you're most comfortable with.
Awesome, thank you.
Got folks in the chat sharing San Francisco, San Diego, LA. We've got Sacramento, Sonoma. So much like our other events, we have really good representation from across the state. We'll give everyone another second to get their responses in. And then go ahead and go to the next polling question. And this one's to help us better understand who you are. So how do you identify? A family member, parent, caregiver, a consumer peer, if you're with one of our NAMI affiliates or a community-based organization, or if you're a provider, you're working with the county or the county behavioral health system, however you would like to check that box today. Okay. We've gotten a chat, quite a few folks also identifying as family members as well. So thank you all for checking those boxes. And again, just for your participation here with us today. I know that the beginning of the school year, I know that there are parts of our state that are under evacuation with wildfires. You know, there's still the ongoing COVID-19 pandemic. And so we really just appreciate all the time that you spend joining these events and asking questions and doing what you do to support communities. Before we get started, I'd like to introduce Jessica Cruz. She's the CEO of NAMI California, to provide welcome and introduction to our guests today.
Thank you, Angela. And yeah, thank you everybody for being here. We are in an amazing time in California. You know, we've all been the last 5 months through the pandemic, and then now we're hit with heat waves, we're hit with lightning storms, and now it seems as if our whole state is on fire. I know here in Sacramento, it smells like a campfire, and when you walk outside the door, there's a layer of ash all over like our patio furniture and everything. And so we really appreciate everybody being here and staying true to NAMI and NAMI's mission, and as we bring our families and individuals and stakeholders together to really hear from the leaders within California. We're so excited to have CSAC representatives here today. The counties, the California Association of Counties actually works in tandem with the California Behavioral Health Directors Association. And I'm sure that both Farah and Rashina will talk about kind of who they are and what they do, but they're a very important player here in California. They represent the counties as a whole, and we have two amazing partners here with us today. Farah, I'm gonna read, even though I know Farah well, I'm gonna read so I don't miss anything, and also for Rashina. So Farah has worked in public policy for 20 years, and she specialized in California health and behavioral health care programs and funding at the county level. She works as a legislative representative for CSAC, and she's really an expert in really behavioral health funding as a whole, 91 realignment, 2011 realignment, Affordable Care Act, Medi-Cal, drug and alcohol programs. So she understands all the different funding aspects when it comes to behavioral health and how it's funded within the state and locally within the counties. She actually began her career as a journalist. I didn't know this until just now, which is kind of cool. And she served as an assistant editor at the California Journal before joining the California State Association of Counties in 2001 to provide public affairs expertise. Her public policy and complexity of county issues soon lured her away from communications and into advocacy, where she now combines her writing and speaking skills and loves working with people with robust advocacy like us and solution oriented outlook. So she fits right in with NAMI, and it's been a pleasure to work with her over the years. And Rashina, she served with CSAC for 2 years as the Health and Human Service Legislative Analyst. In her capacity, she works at federal, state, and local leaders to develop implementation policies that implement California's safety net programs. but she has a lot of experience before she came to CSAC, working at Department of Social Services here in California, as well as Sacramento County Human Assistance, where she has expertise in federal and state program eligibility and county implementation procedures for programs such as CalWorks, CalFresh, Medi-Cal, and Stage 1 Child Care. Thank you both for being here. I don't want to take up too much of this time introducing you because I know you have a lot to cover, and I'm very excited to welcome you both here today.
Thank you. Okay, I think we can go to the next slide. Okay, so I just want to give a quick rundown on our agenda for today. We're going to discuss who we are as an organization, as staff members, the role of the county boards of supervisors in the behavioral health realm, and then key areas of importance or concerns for our membership. These are things that they have brought up to us or ideas that we've told to them, how we can work together as a community in advocacy, and then a section so we can have a quick discussion and work on questions. We can go to the next slide.
This is Farah speaking, and I think everybody kind of understands or knows, you know, that you live in a county. You probably know there's a lot in California. We have 58 counties here in California, this really beautiful map that Roshina found. And, you know, it ranges from tiny Alpine with about 1,000 people to Los Angeles, which is one of the largest counties in the United States, with more than 10 million people. And so our challenge is representing all these different and diverse counties. Of course, the rural ones, those are our tiny little guys, our suburban ones, and the urban areas. While they have challenging issues for each of those areas, they're, you know, demographically different, geographically, even their climates can be different. What we do as an association is represent all of them and find the commonalities between this sort of ragtag group of counties. And so you can see by the map, it's very diverse as far as the size of the county and location. Next slide.
Okay, so CSAC as an organization has been around for over 100 years. What started out as very informal gathering of peers to discuss some of the issues that they see in their counties or talk about, you know, best practices has now been formalized to be a full purpose to represent county government before the California legislature, within state agencies, departments, with the federal government, and as well as the public. And so as Farah said, we have 58 counties, and as an association, what we strive to do is find that one voice and then speak on behalf of that one voice for 58 counties. Where there can be a lot of differences, we do try to find where are the similarities. A lot of it is within funding, but there's different policy areas where we have similarities across the state, and that's when we become their voice. So we have our legislative hand, but we also have what we call the CSAC Institute that provides education for our membership, and that could be educating them on state government or what the role is of federal government and policies to our membership, as well as key department heads within the county or elected officials like CAOs or sheriffs and things of that nature. Next slide.
CSAC as an organization, we have on our legislative team about 15 staff. We cover a broad range of policy areas. Roshina and I are part of the Health and Human Services team. We have another person, Justin Garrett, who works on social services. We also cover agriculture and environment and natural resources, criminal justice, which you know, goes by a number of different names, administration of justice in our county speak. We have housing, land use, and transportation, and we, you know, touch on every policy issue from, you know, Indian gaming here in California to local streets and roads to, of course, health and human services, and really health and human services for counties is a giant part of not only their budget, but their operations. And it's also something that distinguishes counties, which we'll get into a little bit later, that we provide these services that no one else provides. So Rashina and I are 2/3 of the HHS team at CSAC, and you'll see pictures of us so you can kind of see who we are. We encourage you to, of course, use the chat function and the Menti app to share your views, but if you want to contact us or contact anybody at NAMI California and they'll get a hold of us, we're happy to talk to you directly as well. Rishi? Yeah. So we're going to roll right into what's a county. And we just wanted to throw this up there. You know, we don't want to be too much like, you know, your history class at school or the class your kids are probably currently in right now with distance learning. But it's a subdivision of the state. And as such, it's a little bit different than our friends in the cities or even special districts, which we don't even have to get into. But counties, what we like to say is that everybody in California lives in a county. And so we're responsible for the governance and policies that cross the boundaries of everything. So county health and human services programs, including behavioral health, are supposed to be provided county-wide by the county, regardless of what city you live in, regardless of where you are. And that's really important. We also operate the jails. And so if a city of Sacramento police officer makes an arrest, they take that person to a county jail. So we maintain those local incarceration systems, which are under great stress right now, rightfully so. And is an area where we at CSAC are working hard on to understand how to make it work better. But we also have a number of other duties that are different than cities. And we also contract with the state to provide specialty mental health services. And so we're the only entity that does that. We provide the Medi-Cal specialty mental health services. Now, counties may do it a number of different ways. They may provide it themselves with county staff and county clinics, or they may contract with local community organizations and staff to provide those services. But counties are the ones that are responsible for it on behalf of the state. It's a good thing because counties are the closest to the people, and that's why we do a lot of these contracting. Not only do we contract for specialty mental health services with the state, we do Medi-Cal eligibility, we do indigent health care, we do the administration of programs like CalWorks, CalFresh, and the WIC program. And so counties play a key role, and because we're located in communities, the state more than 100 years ago thought that counties were the best place to deliver these services. So that's why we do it that way in California. Not very many states do it this way. California, as usual, is special in this way. But we really have found that it works well because we are closest to the people. Our folks, whether they are county employees or contracted employees, are more culturally competent. They typically live in the communities they serve. And you know, we think it's a good way to have these really important government benefits closest to the people. It also does put us into a little bit of a rock and a hard place, though. The federal government, which provides a lot of funding for Medi-Cal and CalWorks and all those things that we administer on behalf of the state, doesn't know we exist. The federal government looks at the state as the single state agency. And so we're kind of the in-between. And so when there's a disagreement between the federal folks and the state folks, or when there's needs for counties, sometimes we're sort of the monkey in the middle, or as many of you who are them, a middle child, of which I am one. And so we occupy a very interesting space. We have to work very closely, as Roshina mentioned earlier, with our state and federal partners. And while we take this role as sort of the provider of these services incredibly seriously, it can also be challenging at times. Our boards, there's 58 counties, 58 boards, and there's in each county, there's 5 Board of Supervisors members. They're elected locally, and they are nonpartisan. These are some of the few offices on many ballots that you'll see that are nonpartisan. And that's another thing that we work really hard in representing the diverse 58 counties, is doing so in a nonpartisan way. Rashina, do you want to talk about San Francisco for a quick second?
Yes, so I grew up in San Francisco, so it's my hometown. Go Frisco. But they're a little bit different. They have 11 board members. They're also a city and county, so they make things a little bit more tricky with saying just, we have 5-member boards, but San Francisco has 11.
Yes, and the last thing I'll add before going to the next slide is that while the supervisors are elected in a nonpartisan manner, they do carry their personal and theoretical preferences with them. And you'll see that on many boards of supervisors, where some issues such as taxes and land use, you'll see that you can see the party lines of how supervisors vote. But overall, they're elected as a nonpartisan member of the public. And that's something we cherish at the county level. Especially nowadays, it would make it very hard for a county to function, and counties, while they are headed by elected politicians, they have to function. We have every resident in California depending on these critical services. And so that responsibility overrides all with the boards. Next slide, please. Thanks. This is kind of just an example of what an org chart would look like. We don't expect you to, pore over this, but just to show you that we have the board who are elected by the residents every 4 years. And then typically a county has a county executive or county administrative officer. And depending on which county you're in, you may know that you have one or not. These folks are the ones that kind of behind the scenes are the managers of the county. They take their direction from the board. And for the most part, they like to remain behind the scenes. If you are seeing your county manager or executive's name in your local news headlines, that means something's going on that's probably not good. We have a couple things currently, like in Sacramento County, and I saw several people from Sacramento here who we just had an issue last week where it was revealed that the Sacramento County Board of Supervisors gave the bulk of their federal CARES Act funding to the sheriff. And that was a decision by the county administrative officer that the board went along with. And so that administrative officer, his name has been in the headlines quite a bit, rightfully so. If you hear about the county executive, like I said, it's usually because there's some sort of controversy going on. As we said, we have the residents at the top because the board is elected. They can be recalled. We have other countywide elected offices, and the only thing I really want to mention about that is the county sheriff. You'll see the county sheriff is elected countywide, and so they're a single person representing the whole county, whereas each supervisor, counties do it 2 ways. One is each supervisor has a district and they're elected by the voters in their district, in their part of the county, or they're elected county-wide. It's a mix. But the sheriff is the only one is the single person. It's kind of like the difference between your senators who are sent from each state to Congress versus the president, where all 50 states have weighed in on their election. And so the sheriff takes that authority quite seriously as well. And so there's often, as I mentioned in the example of Sacramento County, some tension with the county sheriff. Of course, criminal justice activities are a core government service, which are under examination right now. And so the sheriff is an important part of the community, but in many places, there's a lot of tension between the sheriff and the board, mostly over funding, because as Rashina said earlier, we do a lot on the funding side, but really how the sheriff is operating, what their officers are doing, how the department's doing, how they are treating inmates, any number of those things are solely under the purview of the sheriff. So that is the one office I do want to flag for you guys, that there can be tension within the county family, and especially when it comes to issues of behavioral health. We've seen improvement in the last, I'd say, couple years with some terrible incidents with law enforcement and those who are living with mental illness. And I think for the most part, county sheriffs and county boards are on board with learning, doing more training, having multidisciplinary teams, having sort of mobile units or strike teams with a mental health professional and a law enforcement person. But we still have a long ways to go there. Next slide, please. We have a question. So if you have your app, the menti.com, you've got your code in. And we wanted to ask, have you ever engaged with your local county boards of supervisors in any way? We know that many people here on this town hall are interested in behavioral health. But you may have also interacted with your board of supervisors at a town hall when they're, campaigning for their office, or maybe you had a land use dispute that you went before the board of supervisors about. There's any number of reasons that people interact with their boards, both good and bad. So any interaction you've ever had, we'd love to know. Okay. Yes, we're seeing some results here and some people are responding in chat as well. What we want to do today is make sure that you know what the board is and does, and give you some ways to interact with the board, because as we go through the role in behavioral health, you'll see that they're a critical portion of how behavioral health is provided in your community. Thanks. Next slide.
Okay, so what is the role of the county board in behavioral health? And so, as we previously stated, the boards are responsible for overseeing the budgeting and managing of funding streams for all of the different programs throughout the county, and behavioral health is one of those. And then they're responsible for the operation of the county behavioral health through Medi-Cal, especially mental health plans, and drug Medi-Cal. Additionally, there are local mental health commissions and boards, to which the Board of Supervisors does appoint members to those boards. Additionally, one supervisor in every county sits on that board. And so that is an area where they have a lot of, they're seen a lot by those members who are part of the local commissions and boards, where they have public people who sit on those boards as well. And so that is probably an area, if you're in the behavioral health sphere, where you've probably seen a supervisor or interacted with them. They're also responsible for collaborating with community-based organizations. That can be in an informal way and formal way. There's been a lot of counties that have formalized partnerships within their schools. And as we talk more about, prevention efforts and when to introduce mental health to children, you'll see more of those partnerships happening on the county level, and that's been very key. And then criminal justice, of course, our administration of justice. There's been a lot of collaboration between criminal justice reform advocates and then their board members, because they're over a lot of the operation of the county jails. And then just the overall supervisors aim to work with everyone, including advocates. And so there are certain things that advocates can do in order to get in front of the board or have those partnerships and become more involved with the policy in that area. Okay. Switch slide. Farrah, you're on mute.
Sorry, this is a very simple slide. I had a dog barking a moment ago, so forgive me if that occurs again. It is likely to happen. Rashina put this slide together, and it looks simple and elegant, and it's one of my favorite slides. But underneath it, and many of you probably already have some sense of this, there's incredible complications with each of these funding streams. And this is really where CSAC does a ton of work, working with counties, working with the State Department of Finance, working with the legislature, and then of course the federal government on county funding for behavioral health. So we'll focus on behavioral health here. Behavioral health is unique in counties in that it has several different funding streams, including 1991 Realignment and 2011 Realignment. And you've all probably heard that word, and it's one of those things that seems esoteric, and it is, frankly. A lot of it doesn't make any sense. I'm the first to admit it. But these funding streams provide state funding, sales tax, and vehicle license fee funding. So when you register your car, part of that fee you pay, strangely enough, goes back to your county and helps fund behavioral health and social services and public health. There's not a nexus there, as you can tell. It's a little bit of a weird thing to do for 91 and 2011. But what it does do, and we started it in 1991, is it provides a funding stream to counties that's outside of the state budget process. Before 1991, we had to go every year to the legislature and say, hey, we're serving 40,000 people, we have this much in costs, can you please fund us? And then we'd have to live with the funding that they gave us or didn't give us. And in 1991, there was a recession at the time. So by diverting VLF and sales tax funding directly to the counties, it gave us a solid funding that we could rely on. It saved the state a little bit of money because the funding, because it goes straight to counties, is outside of the state's Proposition 98 education calculation. And so that means for every dollar paid in VLF or sales tax, counties get most of that rather than at least half of it going to education. And so that's something that our education friends were always talking about. But currently under 91 and 2011, the protections that it provides, including that solid funding stream, are critical to counties. I do want to note, and it's like the next funding stream I'm going to talk about, that it is variable and highly temperamental. During the Great Recession, car buying went down significantly, and sales tax, of course, went down as well. And so while 91 and 2011 realignment revenues we can count on them, we know when they're coming in, we have a historical sense of what they'll come in at, the vagaries of the economy and the world can affect them. We do know, and Rashina will talk a little bit about the effects that are happening right now as a result of COVID and the recession. But just know that they're volatile. We have the Mental Health Services Act funding stream, which has been a game changer since 2004. That's the tax on millionaires. And again, while that's been a game changer and an incredible funding stream for counties, it is also volatile. We don't know yet what exactly it's going to look like with this COVID recession, but we have a lot of concerns about that funding contracting at the very time when we need it most. We also receive a bunch of funding from the federal government through Medi-Cal. When counties serve someone who is on Medi-Cal, the county, using their realignment funding or Mental Health Services Act funding, pays for a portion of the cost of that patient. The federal government picks up the rest. It's anywhere between 64 to 90% is what the federal government pays. And so we have a lot of Medi-Cal federal funding flowing into the state of California through the behavioral health system that provides not only those critical services, but those critical jobs in California. And then counties cobble together other funding. In some areas, they have philanthropic funds. There's local general funds, so that's the money counties have that they can spend on what they choose to do. We also partner with other community members and associations like the United Way to kind of get more bang for our buck in how we do outreach and communication with special populations. We do special programs and services. And right now, counties are doing a lot of partnering with other organizations to not only respond to the COVID epidemic, including the behavioral health effects of the epidemic, but now the wildfire disasters here in California. Next slide.
Okay, so just a quick overview of some areas that we'll be discussing next. Is the key areas of importance to our membership right now. The COVID-19 impacts and the strain on the funding streams, which Farah briefly went over. MHSA uses and flexibilities. This is an area that we started discussing prior to COVID and have been discussing for the last few years. Co-occurring disorders and just educating our membership on the partnership between mental health, or the connection between mental health and substance use disorders, the housing continuum, and then involuntary treatment, which includes assisted outpatient treatment, which is like Laura's Law and conservatorship. Next slide. Okay, so COVID-19 hit in early March, and we're still going through and still reviewing some of the impacts of it, but it's just like a behavior health stressor storm is what I would like to call it. We have high rates of unemployment, physical illness, and then just the lack of social interaction, which everyone knows is part of, you know, overall mental health wellness, is being able to communicate with members of your family, being able to see people who can be your, you know, your safety net. And so we're seeing that in this time, those stressors are being exacerbated due to COVID-19, and they're all happening at once. And so we have this storm brewing with behavior health stressors on top of, you know, the telehealth infrastructure. So basically we've had to change the way of doing business. We've been advocating as an association and really as a state to expand telehealth prior to this for the last few years, thinking about rural communities and places where they can't get in contact with a actual licensed therapist or something of that nature. So we've been trying to expand and advocate telehealth, and now we have had to go straight from in-person meetings to strictly telehealth. And so we're dealing with the lack of infrastructure in certain areas, and the digital divide. There's people who don't have cell phones and they're not able to contact their therapist by phone. So we're working on that issue. Then we have the decrease in federal funding. So as Farah mentioned, how the federal funds flow through for Medi-Cal, well, if you're not having an appointment, then we're not being reimbursed for that service. And so as services are actually declining, even though the need is there, the reaction is that we will not be getting as much federal funding coming down. And then we're talking about the state recession that's happening right now, and the volatile funding streams that are based on the vehicle license fee, the millionaire's tax, and the sales tax. And so based on the state's projections, we have seen that we'll be down funds for the current fiscal year, as well as the next, of over $3 billion of resources for programs. And that crosses all the safety net programs. That's behavior health, that's social services, and that's public health. And we're in a public health pandemic. So it's very serious right now. So these are the current COVID-19 stressors. And then we're gonna talk a little bit about what we're doing to advocate on those behalf. Next slide.
Here's where I'm going to try to talk a little bit about realignment, but not in depth, so you won't fall asleep. We advocated based on those shortfalls with the state's recession and actually the national recession. We advocated for a backfill of realignment. Remember I mentioned that 91 and 2011 provide kind of that base level of funding for counties to offer these services. Well, the revenues dropped so significantly in March, April, May, and June that we had never seen drops of that nature. Also, the Mental Health Services Act in those months, the revenues that were coming in from it dropped as well, over 17%. And so we were facing a hole in our realignment revenue that was unprecedented, never seen anything like that. Now we understand again that realignment, the funding comes in, and when there's a recession, the funding drops, which is not a great design for programs and services that typically go up, or there's a greater need for them when there is economic depression, when people are out of work, when people are isolated. And so we call it counter-cyclical. But until March of this year, we'd never seen a drop in realignment revenue like we experienced then. And so we advocated strongly with NAMI's help, NAMI California. I want to thank Jessica and the whole team for really being with us there every step of the way, advocating in the legislature and our communities about the fact that counties, in order to provide these critical services during this unprecedented time, we need a backfill of realignment. Again, this is unprecedented. We were able, with the help of our folks in the coalition, including NAMI, we were able to get about $1 billion in realignment backfill funds. $750 million of that is from the state's general fund. And then $250 million would be from federal funds if Congress enacts yet another coronavirus stimulus package. So right now, what Rashina and I and others at CSAC are working on is implementing that $750 million realignment backfill to counties from the state. There's a number of technical details that we've been working on. And the one that I want to mention to you is, one, we're just so grateful to the state and for Governor Newsom to providing this unprecedented amount of funding, $750 million, to go directly to counties to be spent on realignment programs. It's just, I still can't believe even that it happened, and we're so grateful. It will save jobs at the local level and help us continue to provide these services. Now, please understand, it's not the full solution. We were facing over last year and this year a $3.3 billion shortfall from reduced revenues. So that $750 million is not a lot, but it's enough to probably stave off a lot of the deep, deep cuts that we were facing at the local level. So we're very grateful for that. We're also working with the governor's office. He has made the receipt of the realignment backfill funding for each county contingent on a county complying with the public health orders. And that's something we've been trying to hammer out. We think we have a pretty good deal on that. The Governor Newsom will be introducing budget bill language in the next week or so that outlines how counties get the realignment backfill funding. It'll filter to counties the same way that realignment funding does already. So it's proportional and no county loses out. And if a county isn't complying with the state public health orders, there's a mechanism to claw back or take back a little bit of a county's 1991 realignment. We don't like it, but the governor felt very strongly that he wanted to have some sort of incentive for counties to continue to comply with and enforce the state public health orders. And so this was the arrangement we reached. We developed it with the idea in mind that no county would ever be penalized. It's only for this current fiscal year, which is what the backfill amounts are for as well. And so we hope that no county would ever have to have a month of their 1991 realignment revenue clawed back by the state because they're not complying. But this budget bill language that should be out in the open soon, hopefully, that's what this budget bill language is about. Again, I want to thank NAMI and NAMI affiliates and a wide group of behavioral health stakeholders who just put their full weight into this and really, really helped save us in getting this realignment backfill. Next slide. So I want to talk a little bit about Mental Health Services Act now that we've kind of talked about realignment and the hot issue there. Mental Health Services Act, as you know, has been a hot issue as well. CSAC, as part of the conversation, convened a mental health working group in December, last December. And of course, Governor Newsom in his January budget, January 2020, it seems like so long ago, also outlined MHSA as a key priority for his administration and looking at reforming MHSA. There's a lot of news stories and a lot of confusion out there about what counties are doing with their MHSA, whether they're actually spending MHSA, and what role it really plays in the overall behavioral health system that counties provide. Our working group was comprised of supervisors, behavioral health directors, and county administrators. And we came up with 7 key priorities for MHSA. And you know, you'll see them here on the screen. None of these are surprises, nor are they barn burners. You know, it's not like blazing a trail. Of course, we want statewide accountability. Of course, we want increased transparency. I think the key that we really see is the flexibility in Mental Health Services Act to focus on core priorities. The Mental Health Services Act is very proscriptive about how counties can spend funding. And as we've seen with about 15 years of time under our belts with spending MHSA, we've seen that some of that rigidity has prevented some counties from spending the funding. And so our overall goal is to increase some of the flexibility with MHSA funding at the county level while preserving the critical stakeholder input, increasing transparency, and making sure that accountability controls are still in place. To do all of this, all these 7 things you see right here on the screen, requires changes to the MHSA and very carefully thought out changes. And so our little working group, we didn't, you know, suggest changes to language. We didn't put forward a bill to make these changes. We were beginning to work again with CBHA and others on talking to the legislature about what we think needs to be, what the troubleshooting is in MHSA and where we can think changes are good, and then work in a collaborative way to make those changes. Well, in March, COVID hit. And one silver lining of that is that these flexibilities and some of these things that I'm talking about, other stakeholders, including NAMI and other groups, had also seen as an issue. And when COVID hit and suddenly we had to pivot to an almost entirely telehealth system and unprecedented stressors on the behavioral health system, especially fiscal stressors, suddenly the administration was open to talking about these flexibilities in the emergency situation. And so CBHGA convened us and NAMI and all the kind of mental health stakeholders in Sacramento, which is a big group, and talked about, okay, what flexibilities do we need right now to deal with this crisis? And came up with about 6 proposals, which were shared with the governor and were eventually signed into law. Now, these flexibilities are temporary, and that's a really important point. It wasn't a drastic permanent change to Mental Health Services Act. Really, the flexibilities that the legislature granted us during COVID and for this fiscal year, and if COVID goes further or longer than this fiscal year, we'll talk about that. But really, these are temporary flexibilities with MHSA that allowed us to pull from reserves right away, that allowed us to use innovation funding a little more broadly, that allowed us to use some of the funding for technology. Rashina talked about pivoting to telehealth and the digital divide. We need technology, not only for the clients, that's critical, but the behavioral health workers as well. And so these flexibilities were signed in the Budget Act with the support of this large stakeholder coalition of which NAMI is a part. And we're really excited about that. And we want to see how it goes. So we're going to keep close track of what counties are doing, how they're using those flexibilities, those temporary flexibilities, and hopefully we'll have some lessons learned from them so that when things calm down again, and we have to believe that they will, when they do, we can sit down with the administration, we can sit down with NAMI, other interested stakeholder groups, and really think about ways that MHSA, it might be useful to change the MHSA thoughtfully with the commitment to stakeholder engagement, community-based services, and transparency and accountability. So our little working group is not meeting anymore, and sorry I have some background noise right now, has concluded their work with these sort of 7 things we want to pay attention to. I do want to note, even within our working group, and Rashida and I didn't really mention earlier, but our work is informed by also personal lived experience in the behavioral health world. And that came really close to home with our MHSA working group. We had a Supervisor Adam Hill from San Luis Obispo County, who was on our working group. And I have to share the unfortunate news that he died in early August as a suspected result of by suicide. So to have a county supervisor who is engaged on behavioral health issues die as a result of suicide during this process while we're working on these issues really brings it home. And I know many on this town hall right now are family members with lived experience and loved ones who have experienced this pain or fear living in this kind of pain. And so we're trying to take a few moments and honor his memory with our membership, of course, and the people of San Luis Obispo County. But I just wanted to mention that to say that county boards of supervisors, sit at a dais and they are in charge of the purse strings and they do make policy for the county, but they're also people too. And I have continually been pleased at the level of interest among county supervisors on behavioral health issues. With Supervisor Hill's death, that's a reminder that we wish we didn't have, but it is something that we're going to keep in mind as we move forward. And we appreciate his work to help us identify flexibilities with the MHSA, and we're hoping to carry that work forward. Next slide. A good poll. Okay, it's time for Minty.com. Are you currently involved in efforts addressing substance use disorder in mental health? We're asking this question because Rashina's going to talk about it in a second. I see a couple yeses on the chat. Some yeses on the Mentimeter. Yep, some more yeses. Give it another minute for others to participate. Also give us a little bit of a breather from the sort of heavy stuff I was just talking about. Lots of yeses in the chat. Okay, can we go to next slide and Rashina?
Okay, so co-occurring disorders. I can say that I think this is an area where our membership may have been a little bit slower to get on board. I think the stigma for mental illness is there. But when we spoke about substance use disorder, we had to shift the thinking from substance use abuse to disorder. And so when we started using behavioral health, we had to keep pounding that it's substance use disorder and mental health. We have certain populations, particularly in prisons and in the criminal justice system, that have a higher percentage of this dual diagnosis. And you see substance use disorder and mental health joining together. And so we wanted to make sure as an organization and as a membership that we keep discussing those areas. We talk about MAT treatment and things of that nature. And so this is an area that we've done a lot of work with our membership to get them on board. And so we also talk about this with our membership in regards to workforce decline and just the workforce shortage in general. we've had a behavioral health workforce shortage that has been documented for a while now, but particularly when it comes to those, the intersection between mental illness and substance use disorder, do we see a larger need for those people who can work with those populations and with this population that have both disorders at once. And so we've been working with the legislature. I think they have come, like our electeds, the state electeds have gotten to an area where they understand that it's not just a mental health issue, it's also substance use disorder. We have to talk about behavioral health and not just one or the other. And so they're where our electeds are now. And so we're working on many different policy changes to expand that workforce to not just include, the specialized mental health therapists, but also think about peer therapists, peer support. We've been doing a lot of bills with, we've been advocating for a bail bill that's been up for the last few years on this area. So that is an area where we are working with our membership and the legislature really closely. And I think partially is because the funding streams have been so separate as well that, they haven't been able to think about it as one. And that's another area that we've been working with the state on, just to kind of do a payment reform and kind of interchange both of the funding streams so it's under one. And then we can go on to the next slide.
We have another poll question because it's going to segue us into the next slide. I did want to, I'm going to read the poll question and have people respond. And then I do want to build on what Rashina said a little bit about the intersection between behavioral health and substance use disorder. Our Mentimeter poll is, have you or a loved one experienced homelessness or a housing challenge as a result of mental or behavioral health issue? I'm going to talk about housing, which is a huge issue here in California in a minute. But the intersection of behavioral health, which is the intersection of mental health and substance use disorders, used to be two very separate disciplines. If you were going to school to be, focus on substance use disorder or substance abuse, as it was called then, you never really intersected with the folks who were going there to be psychiatrists and work on the mental health side of the world. And now, over the last 2 decades, really has combined to have an umbrella of behavioral health. Now, while we recognize there are a large percentage of folks who are living with a mental illness also live with a substance use disorder, it's not everybody. And so we don't want to paint the picture that everybody living with mental illness has a substance use disorder and vice versa. But it is important to know, to have specialized not only workforce, but options for folks who do have both. Typically with substance use disorder, there are medical issues that also need to be addressed. And so it's just really important to have a skilled, broad-based workforce to be able to meet people where they are. And so the intersection of those two things combining into behavioral health is just an important way for us to talk about it to make sure that nobody's left behind. So on the Mentimeter question, we have a lot of yeses. Homelessness or housing challenges as a result of a behavioral health issue. Next slide, please. That's where we want to talk about the housing continuum. It's easy to talk, and we hear it and see it in the headlines every day, about those who are homeless, those with living without shelter. It's almost interchangeable in media and conversations that people assume they're also living with a mental illness or a substance use disorder. This is not true. The federal government thinks it's about maybe 30% of those who are living without shelter also live with a mental illness or substance use disorder. By no means is it even the majority of folks who are on the streets. However, there is part of that stigma, and many people view those who are living on the streets that say they must have some sort of mental illness. Otherwise, why would they be living on the streets? it's not that simple, and we're not here today to try to unravel the complications of homelessness in California. It's an issue we focus a ton of time on. We have all of our issue areas at CSAC work on homelessness. But what we wanted to talk about in the behavioral health sphere, for those folks who are struggling with housing and living with a mental illness, it's twice as hard. There used to be a broader continuum of housing for folks who have a mental illness. And that has been decimated. Counties use their funding to provide behavioral health services, and a lot more have been focusing on homelessness outreach to catch those people, and maybe that's not the right word, but to reach those people living with a mental illness or substance use disorder. We have specialized programs to do that, like whole person care, which has been really successful. Of course, we have everything from permanent supportive housing to inpatient facilities to local residential care homes. And one thing I wanted to point out on that housing continuum are the board and care homes. This is another issue I know NAMI has been involved with as well. On all this continuum, from a person who is living with mental illness, living independently on their own in safe housing, to someone who needs either inpatient or inpatient acute services, board and carers fall somewhere in the middle. Really, they are supervised residential housing where the board and care staff help provide medication management, meals, and some activities of daily living. They're a critical piece of that continuum, and folks who are recovering and living with mental illness, it's just a critical sort of in-between service delivery that we need and is going away at a rapid pace, mainly because board and cares can usually only serve up to 6 people in a residential house, and most board and care operators are mom and pop. And with the rising real estate prices and the lower federal reimbursement rate for this type of service, it makes better fiscal sense to just sell the home and take the profit from the real estate sale of that home. And so boarding cares are disappearing at a rapid clip. We have been involved with CBHA and others in an advocacy push for some state funding to help supplement the board and care rates so that those mom and pop operators can stay in business. Counties are struggling mightily with this. Not only do we place folks who are living with mental illness in board and cares, but also folks who are coming out of jail, who are coming from other places, and anybody who's kind of deemed at risk. And so again, I just wanted to throw it out there that we're strongly involved in the board and care issue. We need this piece of the housing continuum, but I also don't want to lose sight that there is a needed housing continuum, and across that entire continuum, the rise in real estate prices and rents is decimating the options for those who are living with mental illness of safe places to live. On that note, can we go to the next slide, please? We have another poll to get you thinking about what we're going to talk about next. Are you familiar with assisted outpatient treatment and or LPS, Leonard and Peter Short conservatorship? I imagine everybody here probably is, but we definitely wanted to get a sense from the audience. So go ahead and use Mentimeter or type it in the chat. We're seeing some yeses and some nos. Definitely AOT. We'll talk about the acronyms. There's a lot of acronyms. Yeah, conservatorships are showing up in the chat. Okay. Good. Well, let's go move on to the next slide and dive into this. So we put it under the heading of involuntary treatment. we could have chosen any number of words. And it's hard really to talk about what we're going to talk about here. Assisted outpatient treatment, or Laura's Law, and conservatorships, because what those mean, or what they're designed as, are involuntary treatment. I know everybody who works with NAMI is very well aware that California has a community-based mental health system, and that counties are supposed to do everything they can to keep someone living with mental illness in the community, rather than like the bad old days, locking them away forever in an inpatient setting. That up until the 60s was really the only involuntary treatment in California. In the 60s, the state passed the Lanterman-Petrie-Short Act, LPS, and it deals with the civil rights for those who are disabled and those who are living with mental illness. And in that law, they created a conservatorship program, LPS, that stands for Lanterman-Petrie-Short, conservatorship. And this is a court-ordered conservatorship for those who are gravely disabled. And so it lays out the rules for the treatment, the court process, how counties who serve as the conservators, typically in LPS conservatorships, and how counties take care of those folks. And the LPS Act outlined something really different in conservatorship law, which is if someone is in an LPS conservatorship, so a court has found a medical professional has recommended that a person be conserved, and a judge has agreed with that and granted the conservatorship, it lasts for only 1 year. And so it has to be either re-upped or reassessed every year. And so people can cycle on and off of conservatorship. And this is a great frustration to many, many folks who we desperately want our loved ones to be safe. And conservatorship is often one of the last safe places for folks. I will say, however, that conservatorship is, and this is the second bullet on the screen, is looked at by many as a solution to get people off the streets, to make folks who aren't complying comply. And what involuntary treatment really means is not only can you place somebody, whether it's in a facility or a residential area, but you can also require them to take medication, and in extreme cases, very rare, force them to take medication. And so it is a very serious issue that treads on civil rights typically, and we have lots of stakeholders and people with lived experience on both sides of the issue of conservatorships. But it really is the last resort. And while the temporary nature of the LPS Act can possibly cause people to cycle on and off, it also is an important civil rights measure or check and balance to make sure that if a person is taking medication and doing well and able to make decisions for themselves and not gravely disabled anymore, it gives them back the power to make decisions in their life. For counties, conservatorship is, like everything in county land, also a fiscal issue. Our county public guardian or public administrator offices, up until a few years ago when conservatorship started to rise, we heard a lot in hearings about, well, you should just conserve those people and get them off the streets. And I say that because we did hear legislators say that sort of thing about kind of the homeless population writ large. Conservatorships don't just happen for people who are homeless, it's anybody who is gravely disabled. But in Sacramento, in the capital, that's almost always what they talk about with homelessness. And it's, again, county conservators are responsible for folks, every aspect, their medical treatment, of course, the treatment for whatever behavioral health issue they're experiencing, their fiscal affairs, where they live, what happens to their assets, and of course, communicating with family and other stakeholders. and as well as showing up in court and writing reports about how the person is doing. So there's a lot of responsibilities at the county level, and public guardians and public conservators are not considered part of the behavioral health system in many counties. They're separate. They're this separate little office, and yet the most people they deal with are people living with a behavioral health issue. And so we're working not only to sort of bring the conservators and guardians into the fold as part of the continuum for behavioral health, but also get more funding for them, not necessarily to increase the number of conservatorships, but to increase the quality of conservatorships. Many public guardians have high caseloads and are not able to visit people as often as they'd like, or provide some of the resources like the housing continuum I just talked about to those who are conserved. The other thing I want to talk about, with a dog barking in the background, my apologies, is assisted outpatient treatment, AOT or Laura's Law. Again, another huge thing in the headlines. And there was a state audit released just last week, I believe, perhaps the week before, about how assisted outpatient treatment is and LPS are occurring in counties. The state audit was directed by the legislature to look at LPS conservatorships, but they sort of veered into AOT, which makes sense because, again, assisted outpatient treatment is another tool that counties have to do intensive outreach to folks and work very, very, very hard to get the folks to get onto medication if that's what they need, or do other things that will restore or help their behavioral health. It also it also allows counties to involuntary medicate people. Again, that's the last resort. Many counties, there's 19 counties out of 58 in California now have Laura's Law. Many counties, it's more of an outreach program with intensive outreach to gain compliance, which is what most practitioners prefer to do. But there are patients who do need involuntary medication. That's typically occurs in an inpatient psychiatric setting. AB 1976 by Assemblymember Eggman is the bill that would make Laura's Law the law of the land. It would make all counties do Laura's Law. Right now, it's an option for counties. And so that bill, I actually didn't look today, Rashina, if it made it out of Appropriations Committee. We'll have to check. But we, CSAC, supported Laura's Law back in 2004. Former county supervisor and Assemblymember Helen Thompson wrote Laura's Law. And so we've always supported Laura's Law as an option for counties. Laura's Law can be very expensive for counties, and many advocates didn't want to see counties put a lot of funding and effort into involuntary treatment options at the expense of voluntary community-based options. And so there's this balance between assisted outpatient treatment and the rest of the behavioral health services that counties offer. And so 19 counties, many of the largest counties, I would say easily upward of 85% of the state's population lives in a county that has Laura's Law. But Assemblymember Eggman wants all counties to do it. Her bill would require all counties to do it unless they want to opt out of doing it. So sort of flipping that opt-in idea on its head. I have a lot of concerns right now about this bill passing, and counties who are under a budget crunch right now who will automatically go, oh gosh, we can't do that right now, so we're going to opt out. So they have a board meeting, they do an official act, an official agenda item, and they affirm and say, nope, we're not doing Laura's Law right now. And my concern is that that means when times do stabilize and perhaps community members and others are saying, hey, county, you really should think about AOT. The revenues are better. There's some really good evidence-based good outcomes from counties that do have AOT. You really should try this. And having that sort of already, the fact that the county said no, I feel will chill that effect, that county considering saying yes in the future. So we've always strongly supported Laura's Law as a county option. And so we have an oppose unless amended on the Eggman bill. It does extend the Laura's Law sunset, which also we strongly support. And that's why we have an oppose unless amended, not a straight oppose, because we agree that Laura's Law should be extended, but we want to keep it optional for counties. The last thing about involuntary treatment, I've mentioned it several times, it's the last resort treatment, conservatorship and involuntary treatment. And Jessica and others at NAMI, as well as other stakeholders, have done a really good job of emphasizing that there should be a treatment continuum. I don't think any of us who have lived experience with behavioral health issues think that inpatient psychiatric or very, involuntary treatment can be abolished. But the fact that we have so many people that do qualify for these services and programs, it does mean that early
Oh, I think we might have lost Farah there for a second.
Yeah, we did. She'll hop back on. She'll text me. And so I'm gonna go on to the, this is her texting me now. Go on to the next slide until she gets back. Okay, so this is where we can discuss some of the stakeholder engagement and advice that we have for stakeholders when engaging the board. And so we say that you should identify the behavioral health advocate or advocates on the county board. As we discussed, there's always someone that has some type of lived experience. When we looked at the poll, a lot of people on this Zoom have family members or are caretakers. And this is no different for people who are on the board. And so there's always one or two and maybe the full board that feel strongly about behavioral health issues. And so when you identify that person, that's the person that can be the strong connection to some of the issues that you see going on in your county. And then identify local organizations. A lot of times local organizations have key partnerships with their boards. It may be with board members, it may be the CAO, it may be the department head, but that is the link to the actual board members and engaging them. And then following legislation. We follow a lot of the legislation for our members, but we also communicate to them when there are public comments, and if there's a particular county in particular where we're hearing a public comment and they're referencing issues that they see in that county, we relay that information to our membership. And so when we say get involved in the actual legislation, we say write letters, public comment, all that information that we can then forward to our membership and let them know what's going on in their communities if they haven't had that contact with a lot of the stakeholders that are involved. And so we link them there. And then it's just, as far as the behavioral health stakeholder pool, there are many organizations at different community levels. Some counties have more than others, but if you can go to a lot of the town halls, like the original chart showed, the residents elect the boards. And so board members are elected officials that are responsible for what's needed in their communities. And if what's needed in your community is a broader range of behavioral health policies or policy changes, that's the time where you can engage with your elected officials and let them know what's needed in their communities. And they should be abreast to those needs anyway. And then I think
I made it back. Sorry, I dropped.
There you go.
I'm back. I know the time has flown by. I think we were ready for the next slide and discussion. We wanted to leave time for questions.
Yeah, so thank you so much. That was such a comprehensive overview. And I think, I don't want to speak for everyone, but I know the more that we have folks present here and the more that I just hear about how the system works, it really starts to connect all the dots, especially, you know, in California, like you were sharing, Farah, just, you know, our system and our structure is so unique and there's so many counties and so many different funding streams. And, you know, with mental health and behavioral health, there's so many, you know, sort of hands in the cookie jar, you know, moving parts. And so I just really appreciate you breaking all of this down. I know that we got a lot of conversation in the chat box. There were a lot of folks sharing resources and information. And so I know that we are a little bit limited with the Q&A session. And so I'll grab a couple questions, but if it works, what we can do is take some of the questions that we weren't able to answer here today, and then maybe I can work with you and Farah, Rashina, on getting some answers for folks and provide that as a follow-up document.
That definitely works.
Perfect. So I'm going to scroll back up here too. There were a few questions that came in. And again, the links and the information shared in the chat box, I'll make sure that those resources are also sent out with the follow-up email. There was some stuff in there about different op-eds and some other resources that were developed on the talking points that were shared today. Let's see. So I'm going to start here. Is there any portion of the 750 million that's available to ARFs?
So the 750 million would flow just like all the realignment typically does. And so it'll be 231 million that goes into the county behavior health system. And so it'll flow like behavior health funds flow through realignment. And so if there's not an actual realigned program for ARFs, so it won't go there, but it'll shore up funding from being pulled over from MHSA or other funding sources in order to go towards ARFs and contracts of that nature.
Okay, thank you. Another one here that came in. How do we as citizens, organization, and stakeholders hold boards accountable? For example, the CSAC Board of Supervisors funding law enforcement instead of investing in people, children, youth, adults, and seniors. And then once within the county, which districts get what? Is it equitable? Kind of how does that work? Or what are your thoughts?
I'll start. Hopefully I don't drop again. My apologies, everybody. It's just, you know, Murphy's Law, right? That'll happen right when we're trying to talk. So with the Sacramento County, that's a great example. I mentioned earlier the CARES Act funding that the county got. They gave the vast majority of it to their sheriff for his costs in fighting COVID-19. There has been, number one, they had a good local newspaper that exposed that. Number two, there's been public outcry since then. And so really that's that last slide that Rashina talked about getting involved, everything from just doing public comment at the board meetings, of course, writing letters, meeting with the board of supervisor member or members who do care a lot about mental health. It varies across boards. Some boards, I can say all 5 folks on that board of supervisors care a lot about mental health. Other boards, there's one who cares a ton and is on the local board and commission and meets with community members. So identify those allies on the board and talk with them about your concerns. As Rashina said, they're elected. So any way you can, you know, advocate, be a member of the public, and then of course you vote with for them is one way. And then how are resources spread across the county equitably? Yes, it is. And so that's another thing that counties, we have to spend funding and services equitably across the county, but we also have to, and especially with MHSA and should be doing, is paying special attention to underserved communities. So COVID is a really good example right now. Our public health department covers the whole county, yet we're trying to get more testing resources and more outreach resources into, right now, Latino communities and other special communities. And so a county budget, the services that we provide are available to all residents, and they need to be accessible to all residents, but we also have to put a little extra effort into reaching special communities. So if there were inequities in spending, typically it would be a little more spending to reach special communities.
Great, thank you. So we've got a few questions coming in, and Rashina and I, when you were getting back on, talked about, I'll pull some of these questions and then I can work with you in the team to provide a follow-up Q&A document, just so we make sure that we get some of these questions answered. Let's see, so I'm gonna grab the last one here. Is there legislation to amend the sheriff from an elected position to a staff position? It's the very last one that came in, and I thought, we'll go with that one.
We'll go with that one. You see the big smiles on Rashina and I's faces. I want to say for the record, the vast majority of county sheriffs are dedicated professionals serving the people of their community. They work well with their board. They work well with their communities. There are ones who don't. I think CSAC would never support legislation that would change the role of the sheriff. I will say that public safety has a spotlight on it now, rightfully so, and the legislature may be moving in that direction. Even when we asked for the realignment backfill funding, some of it goes to the sheriff in 2011 realignment, and many legislators were very clear that they didn't want any money going to the sheriff. And so that, coupled with, of course, the Black Lives Matter movement, and then, these examples like the Sacramento County Sheriff getting all the CARES Act funding, really are pointing the legislature in a direction that could see some limits on a sheriff's power. Again, CSAC wouldn't support anything that would limit a sheriff's power, but we are supportive of making sure that the communities are served, and they're served fairly and equitably. And so we would be engaging on any legislation from that perspective.
Great, thank you. So we are right at 3:30, being mindful of everyone's time. And so I will work with your team. We'll collect the questions and get those out to you all soon. We do have an evaluation. We just ask folks, if you want to share any feedback about this session or the town hall series in general, we would love to hear from you. And we've got, the link is up here. We'll go ahead and put it in the chat box. And then, like we said in the beginning, this is a recorded session. So once the recording is available, we'll share that with all of the materials from today with you all. We'll also post them onto our website where we keep all of the materials from our prior town halls, and you can find those there. The link is in the chat box. It's also here up on the screen at namica.org/town hall. Our next town hall will be September 3rd, and we have the Department of Managed Healthcare joining us to talk about insurance and access. And so if you would like to register for that, you can also go to the same part of our website, which is namica.org/town hall. And then if you have any other questions, any other final thoughts, you can always reach out to me. I know that we did provide Rashina and Farah's email addresses. If you'd like, you can also send me your questions. I can put into the Q&A document as well. But I just, again, thank you everyone for joining us today. And for those whose kids are going back to school, my heart is with you. My kids are 10 and 16, and distance learning is definitely been an interesting thing for all of us. And so I know that might be why everyone's internet is here and there. I think the system as a whole is feeling a little overwhelmed. So just, for all those, and then anyone who is in an area where there's, the wildfires, if there's evacuation, I just hope that you and your loved ones are safe. And if you have any final thoughts, Jessica, before we say goodbye, everyone stay well and be well, and we'll see you next time. Thank you.